Thank you so much for taking time out of your busy schedules to come and join us for this webinar today. I'm going to be speaking alongside one of my close colleagues, Dr. Brandon Sheffield, and we're going to be talking about improving cancer care through better biomarker testing. For those of you who don't know me, my name is Dr. Rosalyn Juergens. I'm a medical oncologist. I practice at the Juergens Cancer Center in Hamilton, Ontario, but I'm actually here in my role as the Medical Advisory Chair for Lung Cancer Canada. For those of you who are not familiar with Lung Cancer Canada is the only national support program and charity that focuses on the needs of patients and their loved ones who are dealing with lung cancer. So please feel free to check out our website, lungcancercanada.ca. Lots of tools and support efforts for patients and caregivers, and again, physicians, colleagues, et cetera. So it's a wonderful resource. So today we're going to be talking about biomarker testing in cancer care. If I reflect back to when I started in practice, the fanciest thing I had to do was try to figure out which chemotherapy I was going to prescribe based on what side effects I was trying to avoid. If I look at now, when I walk into the door of a new consultation, I'm trying to figure out which of a dozen different subtypes of lung cancer a patient might have in an effort to try to help choose the best treatment path moving forward. And I couldn't do that if it wasn't without the support of the diagnostic team. And one of the key players in that diagnostic team is found within pathology. If we don't have a correct pathologic diagnosis, we're not going to be able to put the best treatment characteristics and opportunities forward for a patient. One thing that's critically important when it comes to this diagnostic journey is the speed with which we can turn around, as well as the accuracy with which we can turn around those results. For many different diagnoses, there are benchmarks for the time that it should take for a patient to go from presentation of symptoms to having completed their diagnostic journey. That is not the case in lung cancer. And we know time is critically important for our lung cancer patients. The longer they sit with symptoms of their diagnosis, the higher the burden of those symptoms becomes, and the less likely it may be that we would be able to actually offer treatment to patients. So getting that information as quickly into the hands of the clinician so that they can craft a treatment plan for patients is of utmost importance. So the reason that we're gathering today is Dr. Sheffield is going to walk us through an incredibly important body of work that was completed looking at a national study about where are gaps in the system, really trying to recognize how can we do better to support the speed of the diagnostic journey. So I'm really looking forward to seeing the results that Dr. Sheffield is going to present. So for those of you who are not familiar with Dr. Sheffield, he actually is one of my colleagues who also is heavily involved in patient advocacy. He works with me on the Medical Advisory Committee for Lung Cancer Canada. He actually leads the CPQA end-to-end quality assurance program. You're going to be hearing more about that here in just a minute. And he's the head of advanced diagnostics at the William Osler Health System. And to be honest, doesn't toot his own horn nearly as well as he could or should. He's really revolutionized how care is delivered at the William Osler, and actually for many regions now beyond the things that he has done, not only extend to the people in the Brampton area, but actually to a large portion of Ontario. And we're grateful that Brandon has the backs of many of our lung cancer patients here in this region. So Brandon, I'm going to pass the torch to you. And why don't you tell us a little bit about the CPQA EQA program?
Yeah, thank you. Thank you so much for the great introduction. That was awesome. And hi, everybody. My name is Brandon Sheffield. I'm a molecular pathologist, so I'm also a cancer doctor, and we work mostly behind the scenes within the laboratory, producing biomarker results that help oncologists choose that most optimal therapy. And thanks for coming today. I'm really excited to share with you a new study that was published just a few weeks ago in the Journal of Thoracic Oncology Clinical and Research Reports. And really excited to have just a few minutes here to tell you a little bit about that study. So uh, hopefully everyone can see my screen there. Um, I think that to tell you about this study, we first have to talk a little bit about the CPQA, the Canadian Pathology Quality Assurance, which is a national organization that was started on a volunteer basis to really help laboratories maintain the quality and accuracy of their biomarker tests. And basically, the CPQA will send samples to all of the testing laboratories around Canada and also outside of Canada internationally, and those samples will have known results. Laboratories can then perform their own biomarker tests and compare the results that they get to the known results in order to make sure that they're actually providing correct information to their clinicians and to their patients. This all started with immunohistochemistry, or IHC, which is a modality of biomarker testing that we look at visually under the microscope. And the way this works is we would send a glass slide. This is an actual size image of a glass slide to labs all over the country and the world. And labs would perform their own staining and interpret those stains locally. This is, if you can see tiny little dots on this slide, this is what they would look like under a microscope when we're zooming in. And in this example, labs are staining for a biomarker called BRAF V600E, which is a commonly performed biomarker in melanoma. We also use IHC, or morphologic biomarkers, to test things like estrogen receptor and HER2, which are commonly used to treat breast cancer. And you can see that each lab has a slightly different quality of the stain. This lab's a little bit lighter than this lab. And in weak expressing cases, that can be a problem to interpret. And when we take everybody's result and put them all together, we can scan through and make sure everybody's getting the same result and look out for instances like this one here, where a laboratory is giving a negative result where everybody else gave a positive result. And when we feed that information back to laboratories, they can utilize that feedback in order to improve on their accuracy and take better care of their patients and clinicians. So over the past decade, the complexity of biomarkers has really increased. And we're seeing not just IHC biomarkers, but sometimes gene sequencing using modalities like next generation gene sequencing, or PCR. And often for diseases like lung cancer, we're having a combination of both immunohistochemistry, simple single gene biomarkers, as well as more complex biomarkers like next generation sequencing. And in order to keep pace with that, the CPQA a couple of years ago came up with a new approach to biomarker testing called end-to-end EQA in an effort to grow our approach to proficiency testing to match the complexity that the modern day cancer patient and their oncologists are facing. Here's how this works. We would start with an FFPE block. This is like the type of sample that would be sent from a community hospital to an academic testing center or a reference lab in order to obtain biomarker results. We sent 3 FFPE blocks, and for each one, we prepared a fake clinical vignette describing a patient situation, which would require some biomarker tests with some degree of urgency. We sent those to participating laboratories all across Canada using FedEx that was tracked. So using the FedEx website, we could track when those specimens arrived at each hospital. When the samples arrived, as per FedEx, we started a clock for turnaround time and asked hospitals to please provide all the necessary biomarkers needed to treat that patient and to upload their reports to the CPQA website. When the CPQA website received those reports, the clock for turnaround time was stopped. We then took those reports and distributed them to a team of medical oncologists along with those original patient vignettes and asked the oncologists each to prescribe a systemic therapy or a treatment to the patients. The CPQA team then looked at those prescriptions made by the assessment team of medical oncologists and judged laboratories' performance based on their ability to guide oncologists to the correct systemic therapy and issued feedback reports to each of the participating laboratories. So this was first published last year during a pilot project we did in colon cancer. And what I'm going to show you now in the study that was recently published was the results that we found when we first applied this technique to non-small cell lung cancer, the most common kind of lung cancer. And as we're going through these results, I'd like to share with you just 3 really important facts about lung cancer for those of us who aren't experts in this disease. Lung cancer is actually the #1 cause of cancer-related death for Canadians. It's the #1 killer of Canadian men and of Canadian women. This disease tends to present very urgently, and the death rate of untreated advanced lung cancer is 4% per week. And it's very costly as well. It costs over $400 per week just to keep those 96% of patients alive. So it's very common, very deadly, and very expensive disease. In this figure, we're seeing along the y-axis here, we had 13 laboratories participate. There were, to our knowledge, there are 17 laboratories in all of Canada that provide biomarker testing, and we had 13 of them participate, so a fairly good turnout. On the x-axis here is turnaround time. All of the labs received their blocks, their specimens, on day 0. And shown here in the blue bars, right to the end, this is the time it took each lab to upload their reports to the CPQA website. So the fastest lab finished in 5 days. The slowest lab took 57 days to complete the same task. This dashed line here at the 14-day mark represents the maximum allowable time that biomarkers should take according to both international and Canadian guidelines. And unfortunately, only Lab 2 and Lab 8, 2 of 13 labs were able to meet this mark, with 1 lab that only missed by 1 day. The remaining labs were well outside of that guideline recommended 14 days. These dark blue bars, the first component of the turnaround time here, this is the time in between when FedEx declared that the case was delivered to the hospital from when the block or the specimen was accessioned or received in the molecular testing site. So some labs accession the case on the same day that FedEx had delivered it, but others took many days, some close to 2 weeks, for that specimen to arrive in the actual molecular lab. We don't actually know what was happening during that time, but it could have been held up in a shipping and receiving area within a facility or in some component of the testing process prior to that molecular facility. The remainder of the light blue bar, this represents time from when the block was accessioned to when that result was finalized. And lastly, these black bars inset within the blue bars represent laboratory self-reported turnaround time. So we simply asked each laboratory participant, how long does it take you to provide lung cancer biomarkers? And whatever answer they provided was set in these black bars. And with one exception, Lab 2, each lab actually performed significantly slower than they had initially believed. So this figure summarizes all of our results. It's a little bit complex, so I'll walk you through what we're trying to show here. Across the x-axis here, these are each of the 13 labs that participated in the exercise, anonymized 1 through 13. Down the y-axis, we have each of our 3 test cases. And on the other side of the y-axis, this is the gold standard therapy that was decided upon by the assessment committee. So had we correctly identified the genotype as an EGFR exon 20 insertion, this patient would correctly be treated with an EGFR tyrosine kinase inhibitor or chemotherapy without immunotherapy, and so on. Each lab has a colored square showing their performance. We'll start with the red square. The red square here means that the lab provided an incorrect genotype, and that led every single oncologist on the assessment committee to provide an incorrect treatment. If a lab had a light blue square, that means the genotype was correct. However, either due to poor turnaround time or poorly communicated results, there was heterogeneity where some oncologists prescribed the correct treatment and others did not. With a dark blue square, this means that the lab found the correct genotype, the correct biomarker status, and all oncologists prescribed the correct treatment. So there's quite a bit of heterogeneity here. We're overlaying the accuracy in this top plot together with reporting clarity. This is how easy it was for oncologists to understand those reports, with dark blue being very easy to understand and the light blue square indicating that there was some confusion amongst the oncologist assessors. And then finally, the last variable, which we've seen already, this is the turnaround time in days, simply just putting a number for each of the labs. Now, there are certainly some laboratories that with a very concerning performance, such as Lab 3, that had an incorrect result and had a turnaround time close to 2 months. Lab 4 as well, with a very extended turnaround time, including Lab 1. But there are also several labs that had very excellent results in here. So Lab 2 had 14-day turnaround time within guidelines and guided every single oncologist to the correct therapy. Same with Lab 8 that did this within 5 days, and Lab 13 that did this within 15 days. And what we found when we looked at these results is that the fast turnaround time seemed to also be associated with very clear reports and also associated with very accurate reports. And when we tried to find next, what do Lab 2, Lab 6, Lab 8, and Lab 13 all have in common? We found that all of these labs use slightly different methods. They all use different gene sequencers and different gene panels. But the one thing that was similar between all of them is that they used a single molecular pathologist to sign a single report that had all of those biomarkers available in one spot and one time, so that an oncologist could easily translate that into a treatment option. The labs that did poorly had what we call non-integrated reports. This means that the reports were received piecemeal, where a pathologist might do a PDL1 IHC test on a single report, and then a scientist like a PhD or CCMG accredited geneticist would do a separate report that had gene sequencing findings without any immunohistochemistry, and were relying on a histology lab to give their tumor content and cut the sample up for DNA or RNA extraction. And so when the reporting became very complex, this was associated with delayed turnaround time and also with incorrect results. In terms of the key takeaways from this, it was quite surprising to find that there was such a large variation in the quality of biomarker results for lung cancer patients. So all of these are testing labs from across Canada, and there was more than a 10-fold variation in the turnaround time for results. And remember, the death rate for this disease is 4% per week. and some patients in some regions waiting several weeks longer than others. Certainly, we can make improvements to our turnaround time, to the clarity of our reports, and even to the accuracy of our reports that are really going to help improve outcomes in lung cancer, which is the #1 cause of cancer-related mortality for Canadians. And lastly, just a plea for laboratories to continue to participate regularly in proficiency testing. It's a very critical component to maintaining biomarker quality. And what we've seen so far since we introduced end-to-end EQA testing is that laboratories who have participated serially and continued to do these exercises year after year have all improved with their turnaround time. So thank you very much for your attention. And if you liked what you saw here, the CPQA actually holds a symposium, which is in person in Victoria in just a little over 2 weeks. So if you're interested in learning a little bit more about biomarker quality, we'd love to have you join us in Victoria Saturday and Sunday, June 14th and 15th. So thanks again.
Oh, thank you so much, Brandon, for that wonderful overview. And thank you so much for taking on this work. Quality work is one of those unsung heroes of just healthcare in general, but without quality improvement, obviously we would be in a sorry state of affairs. As I sit and I reflect on this data, Brandon, the one thing that strikes me is you're starting your clock from sort of a tissue acquisition, right? And sending out, for biomarker evaluation. And from a patient's perspective, they've already likely been waiting weeks or months just to get to that point where tissue has been acquired. So I just want everybody to pause and think about that, right? Like when you look at those long timelines, there's probably at least that long, if not longer, prior to that person actually having tissue acquired for us to try to evaluate things. So, that isn't always in our control in healthcare. This part is in our control. And so I think it even just speaks more volumes why it is so important for us to try to make sure that things are efficient as possible when we work our way through the system. Can you talk a little bit about just quality assurance in biomarker testing in general? I feel like Canada, has had a pretty long history of collaboration and collegiality with regards to how the labs have worked together. And I know that you've played an important role in that.
Yeah, absolutely. So I think that we've got a great spirit of collaboration in Canada, and the lab community in Canada works very well with one another. I think that it's nice that we all know each other, and that when we've had new rare markers come up like ALK or NTRK, that Canadian labs have really taken a lot of leadership on the world stage there and been able to complete ring studies where they use very similar methodologies to what we're doing here in EQA. So when something like when we had our first ALK inhibitors with crizotinib and first started doing ALK immunohistochemistry, those first ring studies that were published on and became world famous, those really are the same idea behind EQA. With EQA, we're doing that on an ongoing basis for markers that are not new anymore. So it doesn't have as much sparkle and enthusiasm because we just, the oncologists pay attention to the very first exercise we do. But then as boring or banal as it may be, we just have to continue to do that so that we maintain the quality of our biomarkers so that we're not susceptible to a drift over time. And if we turn our backs on that, and if we don't pay attention constantly to the quality, that we could have a reagent go off, something, a protocol change, or something like the pH in the tap water could change the quality of our staining, and that might be the difference between a patient receiving a correct therapy and an incorrect therapy. So much goes into maintaining that quality, and having an external organization like the CPQA to help manage that. For me, as the lab director at William Osler, I always really appreciate the fact that some of that burden can be taken on by an outside body.
So there's a couple of questions from some of the participants in the audience. One is from a well-known friend. Thank you, Angus, for putting your question in the chat. Angus is a patient himself and a very staunch patient advocate. We're lucky to have him speaking on behalf of many lung cancer patients out there. And from his perspective, and rightfully so, he's like, this is very scary. How do we advocate for better timelines and results for our local labs? What can patients do to bring awareness that this is something that needs to be prioritized?
I think speaking up is important. If by the time you find yourself waiting for a biomarker, it might be a little bit too late. Oncologists at that point will have to advocate to try and find ways around those lengthy delays and look for testing anywhere else we can find it. But if you've experienced a delay like this, I think it's important to speak up about it. One of the key data points from this study was that labs were not able to accurately report their own turnaround times. So for our regulatory bodies in the provinces to simply ask labs, how long does it take, is insufficient to monitor that quality metric for our patients. And probably some form of measurement is required to make sure there aren't centers that are becoming big outliers like this, because a little bit of investment into faster biomarkers will save a ton of money for the rest of the healthcare system. This will avoid emergency room visits. This will avoid interventional radiology procedures. And this will most importantly make sure patients go onto the correct therapy right away.
There's one more question I'm going to try to tackle. We're almost at the end of our time, but they're asking, why labs might be hesitant to adopt an integrated system, showing, that these things are more effective. And Brandon, I'm going to actually try to tackle this one. It's really, really irritating because we actually get new funding for new medications all the time. But what doesn't happen is additional infrastructure support being placed into our laboratories, our radiology departments. And so I might get the shiniest new drug, but it doesn't matter if I have access to a new drug if I can't actually identify who the right patient is to get it. And so if we're not putting investments into the lab, it's not going to be helpful. Same thing with radiology. Would you imagine that I'm prescribing drugs that cost thousands upon thousands of dollars a month, but yet I can't afford to get a CT scan in a timely fashion? So we need to actually take a holistic approach to cancer care and make sure that funding is not only going to medications, but also to pathologists and the labs and things like that. I think that that's of critical importance, is to look at the big picture. And we forget that we don't get funding for things like biomarker development and biomarker management. They get paid to do the test, but they don't actually get dollars and cents to be able to develop new tests or maintain those tests. So I think that's important. So I'm going to wrap up because we're in the last minute here. Brendan, I just really want to thank you for, again, doing this work and putting together this presentation. I really think it shines a light on things that we really need to recognize. This research underscores why we as clinicians and advocates every day need to be fighting for our patients to get their diagnoses as quickly as we can. And I can say on behalf of Lung Cancer Canada, we are committed to try to change these things. Improving access to comprehensive biomarker testing for all Canadians, regardless of geography, is one of our prime foci at Lung Cancer Canada. And this is a study that gives us the data that we need to actually then put forward coordinated action. And I'm really hoping that today's session gets you as fired up as Brandon and I are about this topic. Before we close, I just want to let everybody know that this session was recorded. We will be sharing it following the event, so you can actually then share it on and let other people know who weren't able to attend about this really important initiative. Together through research, advocacy, and policy change, we can close some of these gaps in lung cancer and ensure more Canadians benefit from the promise of precision medicine. So thanks everyone again for joining us today for this webinar. And we look forward to hearing more and more updates, Brandon, about how hopefully the whole country continues to improve. So I'm hoping we can have you back in a year or two, and you're going to show us how we're all doing so much better.
That's the hope. Thanks so much for having me in. I couldn't have put that better myself.